Jaundice. Definition: yellowish discoloration of the skin, sclera, and mucous membrane due to elevated serum bilirubin more than 3 mg/%. The normal is 1 mg/%. Causes of jaundice: prehepatic, hepatic, and posthepatic. Prehepatic: increased unconjugated bilirubin, excess production of bilirubin, or failure to uptake or conjugate it in the liver. Hemolysis, hemolytic jaundice, Gilbert syndrome, and Gregory-Najjar syndrome. Hepatic or hepatocellular: increased both conjugated and unconjugated bilirubin. Defect is at the level of the hepatocyte. All causes of liver cell failure, viral or drug-induced hepatitis, Dupin-Johnson and Rotor syndromes, increased conjugated bilirubin. Post-hepatic or obstructive or cholestasis, increased conjugated bilirubin, impaired excretion of bile from liver into the gut. Extrahepatic and intrahepatic. Extrahepatic: gallstones, cancer head of pancreas, enlarged lymph nodes in the porta hepatis, stricture of the wall of the biliary tree. Intrahepatic: primary biliary cirrhosis, drugs such as estrogen, OCPs, or chlorpromazine. Intrahepatic cholestasis of pregnancy. And finally, causes of hepatic jaundice. Syndromes: Gilbert syndrome, it's autosomal dominant, defect in uptake. Asymptomatic plus or minus jaundice, which increases with fasting. Treatment: nothing, benign condition. Gregory-Najjar type 1, autosomal recessive, and Gregory-Najjar type 2, autosomal dominant, both due to defect in conjugation, decreased glucuronide-transferase. Clinical picture: for type 1, neonatal crenectress and death. Type 2, survive to adulthood. Type 1, because it's fatal, so there's no treatment. Type 2, phenobarbital and liver transplant. Dupin-Johnson, autosomal recessive, defect in excretion, brown pigment in hepatocytes. Jaundice plus or minus right upper quadrant pain and malaise. Treatment: it's benign condition, so there is no treatment. Rotor syndrome, autosomal dominant, defect in excretion, no pigmentation in hepatocytes. Clinical pictures such as Dupin-Johnson, jaundice plus or minus right upper quadrant pain with malaise, and it's a benign condition, so there is no treatment. Then we have comparison between hemolytic jaundice, obstructive jaundice, and hepatocellular jaundice. For pathogenesis: hemolytic jaundice, increased hemolysis of RBCs, increases hemobilirubin. The liver can't uptake hemobilirubin completely, so part of it is retained in the blood, increases serum bilirubin, increasing jaundice. Large part of hemobilirubin converted into conjugated bilirubin and excreted by the liver, so increased stercobilinogen leads to dark stool, and increased stercobilinogen increases urobilinogen, which is colorless, so urine is normal in color. Achuliuric jaundice. For the obstructive jaundice: decreased excretion of conjugated bilirubin into the intestine due to obstruction, so we have decreased stercobilinogen, pale stool. Conjugated bilirubin regurgitates into the blood, increasing serum bilirubin, leading to jaundice. Conjugated bilirubin is water soluble, so it appears in urine, leading to dark urine. Note: decreased bile excretion into the intestine leads to steatorrhea. Bile salts regurgitate into the blood and appear in urine. And then we have hepatocellular jaundice: decreased uptake, decreased conjugation, decreased excretion of bilirubin. Decreased uptake increases unconjugated, while decreased excretion increases conjugated, leads to dark urine. Decreased excretion decreases stercobilinogen, leads to pale stool. In hepatocellular jaundice, decreased enterohepatic circulation of stercobilinogen, so urobilinogen is increased in spite of decreased stercobilinogen. Investigations: for the hemolytic jaundice, in serum, increased unconjugated bilirubin; in stool, increased stercobilinogen; in urine, increased urobilinogen. Bilirubin is absent. Bilirubin never exceeds 5 mg% in hemolytic jaundice as long as the liver is normal. For obstructive jaundice, in serum we have elevated conjugated bilirubin, cholesterol, and alkaline phosphatase. In stool we have decreased stercobilinogen, and in urine we have decreased urobilinogen. Bilirubin is present. While in hepatocellular jaundice, in serum we have both conjugated and unconjugated bilirubin, they are increased. In stool we have decreased stercobilinogen, and in urine we have increased urobilinogen. Bilirubin is present. Clinical picture: for hemolytic jaundice: jaundice mild, lemon yellow, urine normal, stool dark, features of hemolytic anemia. Obstructive jaundice: deep jaundice, olive green, and we have dark urine, pale stool, and other features of obstructive jaundice: steatorrhea, pruritus, bradycardia, bleeding, xanthelasma, bone affection, osteomalacia, and prolonged cholestasis leading to cirrhosis. For hepatocellular jaundice, we have orange, yellow jaundice, dark urine, pale stool, and features of liver failure. How to reach a diagnosis in a case of jaundice? History taking, physical examination, and investigations. History taking: personal history, age, child, hemolysis, adult, hepatitis, old, cancer head of pancreas. Sex: for cancer head of pancreas and hepatitis, it's more common in males, while in stones are more common in females. Habit: alcohol leads to hepatitis. Complaint: yellow discoloration of skin and mucous membrane. Present history: onset, acute hepatitis or stone, gradual, malignant obstruction and cirrhosis. Course: progressive, malignant obstruction, regressive, hepatitis, intermittent stone. Duration: short, hepatitis, long, cirrhosis, and exclude malignancy. Urine: dark in obstructive and hepatocellular jaundice, whilst normal in hemolytic jaundice. Stool: dark in hemolytic jaundice, pale in obstructive and hepatocellular jaundice. Stool in obstructive jaundice is very pale with features of steatorrhea. Just remember, urine is not dark in hemolytic jaundice. Urine is not dark, so stool is dark, while the opposite in obstructive and hepatocellular jaundice. Fever: hepatitis, pre-icteric phase, low-grade fever in cirrhosis, malignancy. Vomiting: early viral hepatitis. Pain: right hypochondrium, radiates to the right shoulder, stone. Epigastric pain radiating to the back, cancer head of pancreas. Pruritus: obstructive jaundice. Marked loss of weight, malignancy. Past history: hemolytic crisis, history of drug intake or biliary choric or hepatitis with bilharziasis. Family history: hemolysis or Gilbert's syndrome. Physical examination: general manifestations. Color of jaundice: hemolytic, lemon yellow, obstructive, olive green, hepatocellular, orange yellow. Cachexia in malignancy. Skin manifestations of hemolytic jaundice: leg ulcers. For obstructive, itching and xanthelasma. For hepatocellular, the skin manifestations of liver cell failure. Skin pigmentation and clubbing in primary biliary cirrhosis. Subcutaneous hemorrhage or ecchymosis. Hepatocellular due to decreased coagulation factors, and in obstructive jaundice due to decreased absorption of vitamin K. Abdominal examination: liver, it's enlarged, soft, tender in viral hepatitis, firm with sharp border, cirrhosis. Enlarged, hard, tender, and nodular in malignancy. Spleen is enlarged in hemolytic anemia, cirrhosis, and hepatitis. Ascites, liver cell failure, cancer head of pancreas. Gallbladder, Courvoisier's law. In obstructive jaundice, stone is not palpable, gallbladder, while cancer is palpable, gallbladder. The stone is not palpable because of fibrosis. Investigations: 5 lab, 5 imaging, and 5 instrumental. Laboratory investigations: liver function tests. Hemolytic anemia, we have elevated unconjugated, normal conjugated, normal SGOT and SCIPT, normal alkaline phosphatase, increased stercobilinogen, and increased urobilinogen. For hepatocellular, we have elevated unconjugated, elevated conjugated, elevated SCOT and SCIPT, and elevated alkaline phosphatase with elevated urobilinogen. The only thing that's decreased is stercobilinogen. Obstructive, normal unconjugated, elevated conjugated, normal or elevated SGOT and SCIPT with elevated alkaline phosphatase and decreased sterco and urobilinogens. Blood picture: features of hemolytic anemia: elevated ESR in malignancy. Serological tests: hepatitis markers and autoantibodies. Therapeutic test: vitamin K injection to differentiate between obstructive and hepatocellular jaundice. Vitamin K corrects prothrombin in obstructive jaundice while not in hepatocellular jaundice. Cortisone test to differentiate between intra and extra cholestasis. Isolated hyperbilirubinemia: increased bilirubin, normal AST and ALT, and alkaline phosphatase. Unconjugated hemolytic anemia overproduction or Gilbert's syndrome or Krieger-Najjar syndrome, while conjugated Dubin-Johnson-Rotor syndrome. Imaging: X-ray, gallstones, barium, swallow, esophageal varices, meal, white seed duodenum in cancer head of pancreas, ultrasound, CT, and isotopic scan. Instrumental: ERCP, PTC, liver biopsy, laparoscopy, and laparotomy. ERCP, endoscopic retrograde cholangiopancreatography, is used to investigate obstructive jaundice and remove obstructive gallstones. PTC, percutaneous transhepatic cholangiography, indicated in obstructive jaundice with intrahepatic biliary dilatation. Liver biopsy after correction of bleeding tendency, technically difficult if ascites is present. Treatment of jaundice. Since jaundice is a symptom, not specific order, treatment depends on the cause. This can range from removal of gallstones to tumors, antibiotics, treat infections, liver transplant in cases where liver is severely damaged. So, causes of recurrent jaundice: hemolytic crisis, gallstones leads to recurrent obstructive jaundice, recurrent hepatitis or recurrent cholestasis of pregnancy, drug-induced jaundice, hemolytic drug-caused hemolysis, sulfa and alpha-methyl dopa, rifampicin, decreased uptake of bilirubin, hepatocellular, halothane, paracetamol, INH, DDT, obstructive, erythromycin, anabolic steroids, PAS, chlorpromazine, and dindivan. Post-operative jaundice. Jaundice occurring for the first time in the post-operative period. Etiology: unconjugated hepatocellular and extrahepatic obstruction, unconjugated hyperbilirubinemia, massive blood transfusion or mismatched blood, absorption of residual hematomas, hepatocellular damage, septicemia, drug-induced liver jaundice, halothane, viral hepatitis, activation of pre-existing liver disease, extrahepatic obstruction, missed stones, post-operative pancreatitis, injury to common bile duct, and sclerosing cholangitis. Sclerosing cholangitis, term used to describe fibrous thickening of the bile duct wall associated with multiple strictures, may be secondary to congenital lesion, operative trauma, or no etiology is evident, primary sclerosing cholangitis. Hepatoma or hepatocellular carcinoma, highly malignant tumor from the time of presentation, leading to death within less than 6 months. Predisposing factors: age, usually more than 40 years, sex, more in males than females by 3 times, hepatitis, HBV, HCV, cirrhosis, especially hemochromatosis, aflatoxins, mycotoxins secreted from saprophytic fungi on stored grains. Contraceptive pills lead to adenoma, not hepatoma. Clinical picture: rapid, unexplained deterioration of condition, encephalopathy, loss of weight, right hypochondrial pain or appearance of local swelling, resistant ascites, paramalignant syndrome, non-metastatic manifestations, CNS, polyneuropathy, myopathy, myasthenia, cutaneous, acanthosis nigricans, dermatomyositis, cachexia, clubbing, endocrinal, due to abnormal peptides secreted from the tumor which may be similar to hormones, insulin-like peptides, hypoglycemia, parathormone hormone, increased calcium, ACTH-like peptide leads to Cushing syndrome. Investigations: hepatoma markers, increased alpha-fetoprotein in 65% of the cases. It can reach more than 2000 nanogram percentage, or carboxyprothrombin, hepatic scanning, CT, MRI, ultrasound, portal venography, portal vein thrombosis, hepatitis B and or C markers, usually positive, liver biopsy, diagnostic but better avoided. Treatment: hepatic transplantation, the result is unsatisfactory, hepatic embolization, injection of gel foam in blood supply of tumor, radiofrequency ablation, medical, systemic or local cytotoxic chemotherapy, adriamycin, unsatisfactory. Surgical resection is a treatment of choice for non-cirrhotic patients. Liver transplantation. A liver transplant is a surgical procedure to remove diseased liver and replace it with healthy liver from a donor. Indications: we have 6: hepatocellular carcinoma, Budd-Chiari syndrome, fulminant hepatic failure, liver cirrhosis of all causes with poor liver function, biliary atresia, failure of bile duct formation, this is the most common indication in children, and finally, inherited disorders of metabolism such as tyrosinemia, alpha-1 antitrypsin deficiency, familial hypercholesterolemia, Crigler-Najjar type 1, Wilson's disease, hemochromatosis, and finally glycogen storage diseases. Contraindications: we have relative and absolute. Absolute contraindications: severe systemic illness, uncontrolled sepsis, extrahepatic malignancy, AIDS, and advanced cardiopulmonary disease. Relative: age more than 70 years, portal vein thrombosis, hepatoma more than 3 cm in diameter, renal failure, severe obesity or malnutrition, uncontrolled psychiatric disorders. Complications: liver graft rejection, acute or chronic rejection, hepatic artery thrombosis, biliary obstruction or leak, post-operative bleeding, post-operative infections, recurrent hepatitis, post-operative malignancy, lymphoma, hepatoma, renal dysfunction, hypoperfusion injury, drug nephrotoxicity. Surgical technique: orthoptic liver transplantation, auxiliary transplantation, split liver transplantation, and finally living donor liver transplantation. Part of the liver, usually the right lobe of the patient's relative, is transplanted. While split liver transplantation, the liver of the donor is split into two pieces to supply two patients. Auxiliary transplantation, the liver is not entirely removed. Immunosuppressive drugs, cyclosporin, prednisone, mycophenolate. Liver donor requirements. The criteria for liver donation include good health, compatible blood group and organ size between the donor and recipient, being between 18 to 60 years old, should be negative for HIV, HBV, HCV, having charitable desire of donation without financial motivation. Non-alcoholic fatty liver disease. Definition: one cause of fatty liver in which there is fat deposition in hepatocytes due to excessive fat, not due to excessive alcohol use. It's becoming now one of the most common causes of chronic liver damage worldwide. Steatosis, isolated fatty liver 80%, fatty infiltration without inflammation. Steatohepatitis, non-alcoholic steatohepatitis or NASH 20%, steatosis with inflammation may lead to progressive fibrosis and cirrhosis. Etiology: primary, idiopathic; secondary, obesity, metabolic syndrome, insulin resistance associated with type 2 diabetes, hypertriglyceridemia, malnutrition, rapid weight loss, surgical gastric and jejunal bypass, Wilson's disease, drug and toxins, imidazole, aspirin, pesticides, cortisone, methotrexate, and chloroquine. Pathogenesis. The pathogenesis of non-alcoholic fatty liver disease still unclear. Hepatic steatosis is due to lipid accumulation, mainly triglycerides within the hepatocytes. Accumulation of hepatic fat closely linked to insulin resistance, which increases lipolysis of peripheral adipose tissue with resultant increased fat influx into the liver in the form of free fatty acids. The injury may be due to direct cellular toxicity of excess free fatty acids, oxidant stress, or lipid peroxidation. Clinical picture: usually asymptomatic, pain, heaviness, discomfort in the right hypochondrium, palpitation, enlarged liver with smooth surface and soft to firm consistency. Investigations: lab, liver imaging, fibroscan, and liver biopsy. Lab: elevated ALT and AST. There is no relation between the degree of ALT elevation and the histological severity of steatosis or fibrosis. Bilirubin, albumin, and prothrombin time are usually not affected in fatty liver diseases until cirrhosis and liver failure develops. Lipid profile: hypertriglyceridemia and or elevated LDL. Liver imaging: ultrasound, CT, MRI, fibroscan, hepatic elastography to assess hepatic stiffness as a marker for liver fibrosis. Liver biopsy: gold standard for diagnosis and is the only way to confirm the presence or absence of NASH. In practice, most patients with non-alcoholic fatty liver disease, they don't undergo this biopsy. Diagnosis: involving history taking to exclude significant alcohol intake, exclusion of other possible causes of abnormal liver tests such as absence of serological evidence of viral hepatitis. Consider liver biopsy for diagnostic and prognostic purposes. Treatment: no specific treatment exists. Lifestyle modification: exercise, dietary modification, reduce sedentary lifestyle, avoid rapid weight loss, not more than 1.6 kilograms per week. Pharmacological therapy: insulin sensitizers, thiazolidindones, metformin, antioxidants, vitamin E to decrease the oxidant stress induced by the accumulating lipids, ursodeoxycholic acid UDCA, and lipid-lowering drugs. Surgical therapy: bariatric surgery for patients with body mass index more than 32.5 kg per meter square with comorbidities or body mass index more than 37.5 kg per meter square without comorbidities. Liver transplantation in a patient with decompensated NASH cirrhosis. Ascites. Definition: excessive accumulation of fluid in peritoneal cavity. Healthy men have little or no intraperitoneal fluid, but women may normally have as much as 20 milliliters depending on the phase of menstrual cycle. Causes: we have transitive, exudative, chylous ascites, chylous from thoracic duct obstruction by lymphoma, exudative increased permeability of peritoneal capillaries. The SAG will be less than 1.1. Pancreatitis, peritoneal diseases, TB peritonitis, spontaneous bacterial peritonitis, or mesothelioma. Transudative ascites, increased hydrostatic pressure. SAG is more than 1.1. portal hypertension with its causes, liver cirrhosis, the most common cause, suprahepatic causes, right-sided heart failure, constrictive pericarditis, tricuspid incontinence or stenosis, Budd-Chiari syndrome, and IVC obstruction, infrahepatic causes, portal vein thrombosis, diminished osmotic pressure, hypoalbuminemia, nephrotic syndrome, nutritional severe malnutrition and malabsorption, end-stage liver disease, poor protein synthesis, miscellaneous, Meigs syndrome, ovarian tumor, ascites and pleural effusion, myxedema. It doesn't cause ascites directly, but it occurs because of myxedema-related congestive heart failure. Chronic hemodialysis occurs in fluid overloaded dialysis. Most of patients also have cirrhosis. Clinical picture. Symptoms: distension, dyspepsia, dyspnea, development of abdominal hernia. Signs: inspection, distension of abdomen mainly in flanks, plus or minus visible veins, divercation of recti, downward shifted everted umbilicus, and maybe umbilical hernia, dilated veins of the abdominal wall, portal hypertension, caput medosa, or IVC obstruction, palpation, fluid thrill, intense ascites, liver and spleen may be filled by dipping method, intense ascites, abdominal masses may be filled in TB and malignancy, percussion, rounded central resonance with peripheral U-shaped dullness in the flanks down to the bed. The resonance over the umbilicus occurs in ascites because bowel floats on top of abdominal fluid. Shifting dullness in moderate ascites more than 500 milliliters is the most important clinical sign of ascites. Percussion in knee-elbow position in mild ascites less than 500 milliliters, dullness around the umbilicus. Auscultation, venous hum may be heard over dilated vein, puddle sign, auscultatory percussion. Pleural effusion may occur secondary to ascites due to passage of fluid through defects in the diaphragm. Differential diagnosis: fat, fluid, ascites, flanks more than center, full urinary bladder, umbilicus shifted upwards, fullness is central, fetus pregnancy, inflatus, gaseous distension, generalized hyperresonance. Investigations to detect ascites: abdominal ultrasound and CT detect ascites even in very small amounts, 30 milliliters, and it also detects the cause, such as liver cirrhosis. Ascitic fluid analysis to detect the type of ascites: serum ascites albumin gradient or SAG. As we mentioned, if more than 1.1, then it's portal hypertension. If less than 1.1, then this indicates exudative ascites. Cell count: ascitic fluid with high RBCs suggests malignancy, TB, and pancreatitis, while if high YBCs, polymorphic nuclear, more than 250 per millimeter cube, then this means spontaneous bacterial peritonitis. TB peritonitis if more than 70% lymphocytes. Culture and sensitivity test, Zell-Nielsen test for TB, amylase to exclude pancreatic ascites, and cytology for malignant cells. Investigations for the cause: for liver cirrhosis, liver function tests and ultrasound; for TB and malignancy, laparoscopy and biopsy. Treatment, we have mentioned it before in the liver cell failure. Refractory ascites: ascites with lack of response to 400 mg spironolactone plus 160 mg Lasix daily with salt-restricted diet for at least 1 week. Lack of response, mean weight loss of less than 0.8 kilograms over 4 days, and urinary sodium output less than sodium intake. There are two types: diuretic resistant and diuretic intractable. Diuretic resistant, lack of response to sodium restriction and diuretic treatment. Diuretic intractable ascites, development of diuretic induced complications which prevent the use of an effective diuretic dosage. Diuretic induced complications: renal impairment, hepatic encephalopathy, hyponatremia, hypo or hyperkalemia. Currently, serial large volume paracentesis LVP, transjugular intrahepatic portosystemic shunt, TIPS, and liver transplant are the mainstay treatment options. Etiology: lack of salt restriction, treated by adequate salt restriction. Severe hypoalbuminemia, IV albumin. Hyponatremia, fluid restriction and IV mannitol. Associated serious conditions, treatment of the cause, cefotaxime for spontaneous bacterial peritonitis. Terminal cause: Levine shunt, peritoneal venous shunt, TIPS, ascites, and liver transplantation. Then we have malignant ascites. Etiology: secondary tumors, stomach, liver, pancreas. Primary tumors, mesothelioma, which is rare. Clinical picture: abdominal masses, massive, rapidly accumulating ascites, aspiration of ascitic fluid, hemorrhagic, massive, and malignant cells. Premature ascites, ascites in cirrhotic patient before shrunken liver, bleeding, hepatitis, and TB peritonitis. And finally, ascites without lower limb edema. We have local peritoneal disease, Diuretic therapy in cirrhotic ascites may cause relief of lower limb edema with persistence of ascites. And finally, ascites precox, which is caused by pericardial effusion. Causes of hepatomegaly: infections, hepatitis bilharziosis, amebiasis, fasciolasis, TB, inflammation, connective tissue disease, and rheumatic disease, infiltration, fatty liver, glycogen storage disease, and amyloidosis, malignancy, primary, secondary, leukemia and lymphoma, congestive, liver, cholestasis, obstructive jaundice, particularly extrahepatic. Mild enlargement, less than 5 cm from costal margin, moderate 5 to 8, and severe more than 8 cm below the costal margin, and it occurs in leukemia, lymphoma, and amyloidosis. Drug-induced liver diseases, acute hepatitis, alcohol, DDT, halothane, paracetamol, and iron H, chronic hepatitis, alcohol, iron H, methyl dopa, fatty liver, alcohol, amiodarone, tetracycline, valproic acid, liver cirrhosis, methyl dopa, iron H, methotrexate, cholestasis, anabolic steroid, PAS, chlorpromazine, dendivan, and erythromycin. Hepatic emergencies, fulminant hepatic failure, esophageal varices, fever, hepatic encephalopathy, hepatorenal syndrome, dyspnea due to ascites, and this concludes the hepatology.